Hello and welcome to this World Asthma Day presentation. My name is Helen Riddell. I'm Chair of the Global Initiative for Asthma GINA Science Committee, and I'm very grateful to the European Academy for Allergy and Clinical Immunology for the opportunity to give you a brief update about changes in the GINA 2021 strategy report, which was published last week. Just very briefly about GINA, it was established in 1993 with the aim of increasing awareness about asthma and improving asthma prevention and management through a coordinated worldwide effort. GINA is independent and it's funded only by the sale and licensing of its reports and figures. It's a global evidence-based strategy that can be adapted for local health systems and medicine availability. It's very widely used and has a practical focus with multiple flowcharts and tables as well as evidence presentations. Importantly, the GINA strategy report is updated every year following a twice-yearly cumulative review of new evidence across the whole asthma strategy. So it's not just answers to individual PICO questions. You can find a description of GINA methodology on that website, and you can download a copy of the GINA report and associated resources from the GINA website. First, just a brief update for the GINA guidance about COVID-19 and asthma, and there's a slide set available on the GINA website with more detail than I'm showing here. Firstly, overall, from large meta-analyses, people with asthma do not appear to be at increased risk of COVID-19 or severe COVID-19, although in 2 studies, the risk of COVID-19 death was increased in people with severe asthma, either having needed oral corticosteroids recently or assessed as having severe asthma in hospital. It's important to advise patients with asthma to continue taking their asthma medications, and particularly inhaled corticosteroids, and to make sure that all patients have a written asthma action plan so they can change their controller and reliever medications appropriately if symptoms worsen. And for patients with severe asthma, the current recommendation is to continue biologic therapy or oral corticosteroids if they are prescribed. Obviously, you need to follow strict infection control procedures if aerosol generating procedures are needed, and that includes avoiding nebulizers wherever possible to reduce the risk of spreading virus. And in terms of GINA recommendations about COVID-19 vaccination, GINA recommends patients with asthma should receive a COVID-19 vaccination with the qualifier that obviously the Pfizer, BioNTech and Moderna vaccine shouldn't be given to patients with an allergy to polyethylene glycol or other vaccine ingredients. However, anaphylaxis to food or insect venom or other medications is not a contraindication. Usual vaccine precautions apply, and GINA recommends that COVID-19 vaccinations should be administered on a different day from biologic therapy for severe asthma, and with a gap of 14 days from influenza vaccination. Now I want to move briefly on to the recommendations in GINA 2021 about treatment of asthma in adults and adolescents. Just a reminder about the key change in asthma management in 2019. The treatment of asthma with short-acting bronchodilators alone is no longer recommended for adults and adolescents. This change is because patients with mild asthma are at risk of severe or even fatal exacerbations. That SABA-only treatment increases the risk of severe exacerbations, and adding any inhaled corticosteroids significantly reduces the risk. So GINA now recommends that all adults and adolescents with asthma should receive ICS-containing controller treatment to reduce the risk of serious exacerbations. So this can be either as regular daily ICS-containing treatment or in mild asthma by as-needed low-dose ICS formoterol taken for symptom relief. Now, in mild asthma, this is what we would call a population-level risk reduction strategy, such as we use with statins and antihypertensives. So individual patients may not necessarily experience or even be aware of a short-term clinical benefit, but the aim is to reduce the probability of serious adverse outcomes at a population level. This is the GINA 2021 treatment figure for adults and adolescents. And at the top, you can see this familiar arrowed circle reminding you of the key steps of asthma management. Assessment, not just of symptoms and lung function, but also of modifiable risk factors, comorbidities, inhaler technique and adherence, and the patient's own preferences and goals. Adjustment, not just of asthma medications, but also treatment of modifiable risk factors and comorbidities, non-pharmacological strategies, and education and skills training. And then review, not just of clinical outcomes, but also of patient satisfaction. Now, the key difference between this figure and the previous ones is that asthma treatments are shown as 2 tracks for clarity. So track 1 is the controller and preferred reliever, and the preferred reliever is as needed low-dose ICS formoterol. In track 1, the patient uses as needed low-dose ICS formoterol whenever they have symptoms for symptom relief. And in steps 3, 4 and 5, they are also taking maintenance ICS formoterol as their controller treatment. The reason that this track is preferred is because using ICS formoterol as reliever reduces the risk of exacerbations compared with using a SABA reliever. Track 2 is shown here below, and here the reliever, the alternative reliever, is as needed short-acting beta agonist. So here in step 1, whenever the patient experiences symptoms, they take a dose of their inhaled corticosteroid whenever they take their SABA reliever. But in steps 2 to 5, the patient is taking either an inhaled corticosteroid or an ICS-LABA maintenance treatment as well. Now, before considering a regimen with a SABA reliever, it's important to check if the patient is likely to be adherent with daily controller, because otherwise they would be using SABA-only treatment. The use of as-needed ICS formoterol in mild asthma is relatively new, and so I just want to briefly go through the evidence that is now available in studies totaling just under 10,000 patients with mild asthma. Compared with SABA alone, as-needed ICS formoterol in mild asthma reduced severe exacerbations by about 2/3 in a large double-blind study in adults and adolescents, and in an open-label study in adults previously taking SABA alone. Compared with maintenance low-dose ICS with as-needed SABA, as-needed ICS formoterol in mild asthma was not inferior in 2 large double-blind studies and was superior in 2 open-label randomized controlled trials. And this was achieved with an inhaled corticosteroid dose around 1/4 to 1/2 of the dose compared with maintenance low-dose ICS. Then other changes, symptom control, lung function, and FeNO, there were very small differences that did not reach clinical importance and were not cumulative over 12 months. And one study in exercise-induced bronchoconstriction showed no significant difference from regular ICS. Now, the other considerations for as-needed ICS formoterol in mild asthma for GINA were that severe exacerbations can occur in mild asthma, and they're often unpredictable, relating to viral infections, allergen exposure, air pollution, and stress. Inhaled corticosteroids are highly effective in mild asthma, but patients are often poorly adherent, especially if symptoms are infrequent. Importantly, even occasional short courses of oral corticosteroids are now known to be associated with an increased risk of osteoporosis, diabetes, cataract, etc. As I mentioned, the differences in symptom control and lung function were not clinically important. And a final factor was that phenotyping is not needed for treatment with as-needed ICS formoterol. And there was no significant difference in treatment effect compared with either as-needed SABA or with daily ICS in patients with high versus low baseline eosinophils or FeNO in 2 studies. I just want to show you two additional figures that GINA has provided, including in its slide set, showing suggestions for where to start treatment along these pathways, depending on the patient's presenting symptoms and clinical features. And there are two versions of this, depending on the need of education. Some additional changes in the GINA report in step 5 relate to add-on non-biologic therapies. So add-on long-acting muscarinic antagonist in the form of tiotropium has been available for many years, but now in 2021 there are several triple combinations available for patients aged 18 years and older. In the review of this evidence, we found that adding LAMA to medium or high-dose ICS-LABA modestly improves lung function, but not symptoms. And in some studies, it modestly increased the time to severe exacerbations requiring oral corticosteroids. However, it's essential that for patients with exacerbations, you should ensure that they receive sufficient inhaled corticosteroids, in other words, at least medium dose ICS-LABA, before considering adding a LAMA. The other add-on non-biologic therapy for which there are additional recommendations is add-on azithromycin taken 3 days a week for example, a 6-month period. This, in a meta-analysis, was found to reduce exacerbations in patients with severe asthma that was uncontrolled despite high-dose ICS-LABA. And it also reduces exacerbations in both eosinophilic and non-eosinophilic asthma. But before considering this option, you need to check the sputum for atypical mycobacteria, check the ECG for long QT syndrome, and recheck after a month of treatment. And importantly, consider the risk of increasing antimicrobial resistance, either at a population or a personal level. So add-on azithromycin is not recommended as a primary care option. So now moving on to treatment of asthma in children 6 to 11 years. This is the treatment figure for this age group. And again, you can see at the top the arrowed circle reminding you of the importance of personalizing asthma management for children with asthma. And that includes taking into account child and parent preferences and goals, and also their satisfaction with their treatment. So you can see that the treatment steps have several options available in them, and I just want to briefly summarize these. The changes in 2021 are more around making sure that the treatment figure reflects the recommendations in the report. So in summary, in mild asthma, there is substantial evidence for maintenance inhaled corticosteroid plus as-needed SABA in children. But of course, we need to consider the balance of risks and benefits. And in children with infrequent symptoms, taking ICS whenever SABA is taken for symptom relief. There are 2 studies in children and adolescents. Although more evidence is needed, this is probably a good option for children with very infrequent symptoms. In step 3, there are 3 treatment options: low-dose ICS-LABA with as-needed SABA, medium-dose ICS with as-needed SABA, and a very low-dose ICS formoterol maintenance and reliever therapy based on this study in children and adolescents. In children, it's important to try options within step 3 before considering stepping up, as there's considerable evidence about variation in response of children within this age group to the different treatment options. Then in step 4, 2 options of a medium dose ICS-LABA with as-needed SABA and low-dose ICS formoterol maintenance and reliever therapy. But consider referral for these children, particularly if they're having exacerbations because of the risks of asthma in children. I just want to finish by mentioning some things that we're planning to address during this year and will report in future years. So GINA is planning to review the definition of mild asthma to make sure that it's relevant and feasible for clinical practice. We are going to review evidence where we can find it for assessment of symptom control in patients whose reliever is ICS formoterol. We'll be reviewing evidence about subcutaneous and sublingual allergen immunotherapy in patients with asthma, and we will update the advice about COVID-19 as new evidence becomes available through the year. So I'd encourage you to download a copy of the GINA report and the GINA Pocket Guide from the GINA website. There's a lot more detail and many more changes in this report than I was able to cover in this brief presentation. But thank you again to Iaki for the opportunity to speak to you. Thank you.